Welcome to This Week in Gastroenterology. This week we're covering 9 notable papers spanning risk stratification and screening, advances in GI and liver oncology, and novel therapeutic approaches from diet to devices. Let's dive in. This week a major theme is refining how we screen for and stratify risk in chronic gastrointestinal and liver diseases. A paper in Gastroenterology addresses the challenge of screening for liver fibrosis, where current guidelines identify a very large proportion of the general population, up to 76%, as eligible for screening. Researchers developed and validated a refined set of criteria using NHANES data. This new strategy targets a much smaller group, just 10 to 22% of adults for screening. The key advantage is that it significantly enriches for disease. The prevalence of significant fibrosis among those eligible for screening more than doubled to 28%. Importantly, those not meeting the refined criteria had a very low risk of fibrosis or future liver-related events. For instance, in the UK Biobank, individuals meeting the refined criteria had a roughly 6-fold higher 10-year risk of developing cirrhosis. This approach could help focus healthcare resources on those at highest risk. In colorectal cancer screening, a post-hoc analysis of the ColonPrev trial published in Gut compared a one-time colonoscopy with a sustained strategy of biennial fecal immunochemical testing, or FIT. After using inverse probability weighting to adjust for differences in adherence, the investigators found that the 10-year risks for colorectal cancer incidence and all-cause mortality were similar between the two strategies. While there was a signal toward lower colorectal cancer mortality with colonoscopy, the estimate was imprecise and not statistically significant. This analysis underscores that a sustained screening program with FIT is a highly effective strategy, comparable to one-time colonoscopy over a decade, highlighting the critical role of adherence in any screening program. Shifting to genetic risk stratification, a large study in the Lancet Gastroenterology and Hepatology examined the role of the HLA-DRB101 O3 allele in over 43,000 patients with inflammatory bowel disease. Carriage of this allele, found in about 4.6% of patients, was associated with multiple severe outcomes in both Crohn's disease and ulcerative colitis. In adjusted models, carriers had a higher likelihood of colonic resection in Crohn's disease and colectomy in ulcerative colitis. They also had a higher risk of perianal disease in both conditions and were more likely to require advanced therapies. Furthermore, these patients tended to start advanced therapies earlier and had a higher risk of treatment failure. This study establishes HLA-DRB101 O3 as a key genetic determinant of severe IBD, suggesting that genotyping could help identify high-risk patients who may benefit from more intensive monitoring or earlier aggressive treatment. In GI and liver oncology, several papers focused on refining treatment and understanding risk. For early esophageal adenocarcinoma, a pooled analysis in clinical gastroenterology and hepatology evaluated outcomes after endoscopic eradication therapy for T1B tumors. The study stratified patients into low-risk and high-risk groups, based on features like depth of invasion and lymphovascular invasion. The results support a nuanced approach. For patients with low-risk T1B disease, endoscopic therapy was highly effective, with a very low rate of extraluminal metastasis at just 2%. However, for the high-risk group, the risk of metastasis was 5-fold higher at 11%, and both all-cause and cancer-related mortality were significantly worse. This highlights that while endoscopic management is a strong option for well-selected low-risk patients, careful consideration and shared decision-making are crucial for those with high-risk features. In liver cancer, a study in the American Journal of Gastroenterology compared the incidence of hepatocellular carcinoma in patients with cirrhosis from virally suppressed hepatitis B versus those with cured hepatitis C. The analysis of nearly 6,000 patients found that the 5-year cumulative HCC incidence was significantly higher in the suppressed hepatitis B group compared to the cured hepatitis C group at 18.1% versus 7.4%. However, this increased risk was driven by those with a shorter duration of viral suppression. For patients with hepatitis B who were suppressed for 2 years or longer, the HCC incidence was similar to that of cured hepatitis C patients. These findings reinforce that HCC risk remains high in all patients with cirrhosis, but also highlight the profound benefit of achieving early and sustained viral suppression in chronic hepatitis B. For patients with advanced HCC, primary refractoriness to the standard of care combination of atezolizumab and bevacizumab remains a major challenge. A multi-cohort translational study in the Journal of Hepatology investigated the biological basis for this resistance. Researchers found that about 40% of patients exhibit primary refractoriness, which is associated with significantly worse overall survival. These patients' tumors had a distinct biological profile characterized by a highly immunosuppressive microenvironment. This included an enrichment of tumor-associated macrophages, reduced T-cell infiltration, and downregulation of the interferon gamma signature. The findings suggest that primary resistance is a distinct biological entity driven by myeloid-mediated immunosuppression, providing a framework for developing rational combination strategies to overcome it. Finally, we turn to novel therapeutic approaches for a range of luminal and liver disorders. For the millions suffering from functional dyspepsia, a randomized trial in clinical gastroenterology and hepatology provides clear dietary guidance. The study compared a low FODMAP diet against traditional dietary advice for patients with postprandial distress syndrome. The low FODMAP diet was significantly superior. A clinically meaningful reduction in symptoms was achieved by over 61% of patients on the low FODMAP diet, compared to just 21 to 38% of those receiving traditional advice. Furthermore, 71% of patients in the low FODMAP group reported adequate relief of their symptoms, more than double the rate in the traditional advice group. This trial provides strong evidence to support recommending a low FODMAP diet for patients with postprandial distress syndrome. In a translational advance for short bowel syndrome, a study in gastroenterology describes a novel device called DREAM, which stands for distal recirculation of enteral contents augmented mechanically. In a large animal model, the device enabled the delivery of full enteral nutrition, despite a 75% bowel resection. This resulted in impressive outcomes, including the prevention of intestinal failure-associated liver disease, a marked reduction in inflammatory markers, and enhanced intestinal adaptation, with increased villus height and restored barrier integrity. By restoring gut-liver homeostasis, this approach represents a promising potential therapy for this devastating condition. And delving into the basic science of liver disease, a paper in Hepatology uncovers a key mechanism driving fibrosis in metabolic dysfunction-associated steatohepatitis, or MASH. Researchers identified a critical crosstalk between macrophages and neutrophils. Macrophages express a protein called SELP-LG, which engages with the cell protein on neutrophils. This interaction activates a signaling pathway in neutrophils that triggers the release of neutrophil extracellular traps or nets. These nets then act as a scaffold to activate TGF-beta, a key driver of fibrosis by hepatic stellate cells. Importantly, blocking this axis with a pharmacological agent, or through genetic deletion, reduced inflammation and fibrosis in mouse models, identifying a promising new therapeutic target for MASH-associated liver fibrosis. If you only have time for one paper this week, make it the randomized trial on diet for functional dyspepsia by Shiha and colleagues in clinical gastroenterology and hepatology. It provides clear level 1 evidence that a low FODMAP diet is superior to traditional advice, giving clinicians a specific and effective tool for a very common and often difficult to treat condition. Here are the key takeaways from this week in gastroenterology. First, for postprandial functional dyspepsia, a low FODMAP diet is superior to traditional dietary advice for symptom relief and should be considered a primary dietary intervention. Second, in patients with cirrhosis, those with suppressed hepatitis B have a higher risk of HCC than those with cured hepatitis C. But this risk normalizes after 2 years of sustained HBV suppression, emphasizing the need for early and durable treatment. Third, the HLA-DRB1*103 allele is a significant marker for severe disease across both Crohn's and ulcerative colitis, identifying patients who may warrant more intensive monitoring or earlier advanced therapy. Fourth, for colorectal cancer screening, a sustained strategy of biennial FIT provides similar 10-year protection against CRC incidence as a one-time colonoscopy, reinforcing the importance of program adherence. And finally, endoscopic eradication of T1B esophageal adenocarcinoma is a viable option for low-risk lesions, but high-risk features significantly increase the risk of metastases and mortality, requiring careful patient selection and shared decision-making. That's your roundup for this week in gastroenterology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.